Thank you, everybody. As Ian said, I trained in Manitoba. I'm a loyal Winnipegger. How many Winnipeggers in the crowd? Raise your hands. Yay. So I've got one favor to ask. I have one favor to ask everyone, and I don't mean to discriminate against the non-Winnipeggers, but for all the Winnipeggers, I don't want to hear anyone cheer if the Jets score while I'm doing my presentation. I've got it taped, and I'm going to watch it when I come home. Is it okay? Yeah. Okay, no problem. So I'm going to be, I'm not a pain expert, but I see an awful lot of people with pain. 20% of our patients are on narcotics, just to give you a sense. Our practice, we look after frail people in the community, in their homes, and assisted living, in retirement homes. The average age is pushing 89 in our practice. We don't take people under 75, with rare exceptions. And we see a lot of people with chronic pain syndromes. And I've been forced to learn about pain, in the trenches. So I'm going to share a little bit of my experience. I'm not going to be talking much about the actual how-to with pain management. Dr. Gallagher is an expert on this, and she's got a great presentation. She's going to talk about it using some case presentations. But what I do want to talk about is what do we do in this age of opiate aversion? Now, I have no conflicts of interest to declare, and the take-home messages here are a couple-fold. The first one is treat chronic pain. Don't ignore it. Don't run from it. Embrace it and treat it. Through using a comprehensive assessment, these people have very complicated syndromes. They often have more than one reason for their pain. They've often got 3 or 4 different pain syndromes going on. Individualize the goals of care. Use opiates judiciously, but use opiates. And we're going to talk a little bit about that for the people where all else fails. And the second take-home message is read the college guidelines. How many people have read the college guidelines? Okay, how many people are terrified because of the college guidelines? Hands are showing. Okay, so my objective is at the end of this presentation, you will not be fearful about prescribing opiates despite the college guidelines, and you'll be totally in keeping with what the college is saying. And I've also added a link for the Canadian guidelines and opiate guidelines in pain management, chronic non-cancer pain treatment. The third thing, goal is that takeaway is that you follow up these people regularly. This is where people get in trouble, that they don't assess people properly. The second thing is they give them prescription, and they said, see you in 3 months. It just doesn't work. When you're titrating people up on regardless of the pain, even if it's an anti-inflammatory drug, or acetaminophen, people who are frail are going to run into trouble. So you need to be able to troubleshoot them. So please follow these people regularly. And when they're doing well, make sure you follow them regularly. It's not good enough to say, I'll see you next year or see you in 6 months, or come in when you're not feeling good, especially when people have underlying cognitive impairment. The next take-home point is document, document, document. If you document everything, I cannot see you getting in trouble with the college. For the people who are terrified about the college, really, I looked at those guidelines on Sunday, reviewed everything with a fine-tooth comb, and I see nothing to be afraid of with those guidelines, and we're going to go through the guidelines, as long as you document things properly. And finally, we're going to take the final part of the presentation. We're going to talk about prevention, because I think there are a lot of ways. We always see get hit by the truck, this person in agony who's on our doorstep, but a lot of these problems are preventable. And not everything is preventable, but there are things that are preventable. And I'd like to share with you some of my experience in trying to prevent some of these chronic pain syndromes. So this is the challenge, I think, right here, is how do we reconcile these two pictures, right? We have people we see every day in our practices who are in unbelievable pain, levels of pain, who say to me, I want to die. And my concern with MAID, my biggest concern with MAID, medical assistance is dying, is that a lot of those people have untreated pain or undertreated pain. And I've seen this, where you really have to negotiate with people. Just wait until we get your pain under control. Give me a month. Give me 6 weeks. And then let's revisit the issue if you truly want to go through medical assistance with dying. And I'm not against medical assistance with dying. I think it's people's choice to make. But I think that it behooves us to make sure we've done our due diligence and treated people's pain, treated their depression, and their comorbidities. So this is the Zeitgeist. that we're dealing with, as Ian said, start out by saying about, people not prescribing opiates. Every day, if you read the newspaper, there's going to be something in the Globe and Mail, the National Post, the Times Columnist, the Moose Jaw Herald, whatever paper you're going to read, you're going to hear about, sadly, about young people who die from opiate overdoses, that every community in this country has been touched by, or you're going to read about opiate overdoses. And unfortunately, when you read this, there was a big article I remember last year, which I found offensive by, I think it was Carly Weeks in the Globe and Mail, who's one of their expert healthcare reporters, saying that the problem clearly lies with the physicians. And this is the argument, is it opiate-related deaths or a public health crisis? Absolutely. We have a huge public health crisis. Number two, doctors are the only way to legally get opiates in North America. The third thing is that cavalier prescribing leads to accidental overdoses, leads to diversion of drugs to addicts, and leads to addiction. And number four is that the addiction leads to chronic misery and death for people, which is true. Addiction leads to chronic misery and death for people. And finally, opiates and other medical treatments for chronic pain are not even effective. So this is what we're seeing, this is what we're hearing, this is what we're reading, this is the messages that are coming out. Does that sound real to people? Am I covering that issue and that cycle fairly well? So I want to share a quick review of some of the recent studies, because you're going to come across this and we can't ignore these studies. And, I'm a believer in evidence-based medicine, evidence-based care. I do research, but you need to be a good consumer of research as well, okay? And we're going to talk a little bit about some of the recent studies. Just earlier this year, there was a big study released in the BMJ looking at the risk for addiction in post-op narcotic use. How many people have seen this paper? It's a very good paper, and I would recommend you look at it, okay? So they used a sample of 1 million people who are post-op opiate-naive people in an administrative database. Remember, you cannot do randomized controlled trials in this magnitude for people. And they looked at an outcome using ICD-9 discharge codes, where they said, does someone at any point in the future, do they get readmitted with dependence or go to an emergency department with a diagnosis of ICD-9 code for misuse or overdose? And they found that the risk was 0.6% per person year, okay? It was significant. There was a significant risk of becoming addiction or having some problem with opiate use for people who are opiate naive before their surgery and were continued on opiates after. And they found that, interestingly, that the relationship was not related to the dosage. So it's not if you give someone, 20 milligrams of hydromorphone or 10 milligrams because they've got severe pain postoperatively versus giving them 2 milligrams is safer. The problem is the duration of use. And when they adjusted for all the cofactors that lead to, that are associated with, opiate misuse or overdose or things like that, they found this adjusted hazard ratio that there was a 20% increased risk of having opiate misuse, going to a healthcare facility with it per additional week of being on opiates. And that there were 3 times the risk. You had 3 times the risk of developing addiction if you had your initial narcotic prescription refilled. So people that didn't have their initial prescription refilled didn't come back 3 months later, 6 months later, on average. Not everyone did. So the conclusion was, and I support this conclusion, that the risk of addiction is real but small. So let's look at the overall picture. 0.6%, that's 6 people per 1,000 prescriptions per year, per users per year. So it's actually a very small use. But if you're the unfortunate person who may be prone to addiction, you're in trouble. You're in trouble, and your risk of all the previous problems that we talked about go up, okay? And I'll just go back, and a second conclusion is that these risk factors could be mitigated by trying to keep the prescription of narcotic to 5 days post-op. And the majority of people's post-op pain can be managed within that time frame. So the problem that we ran into was, when in the study, what they looked at is that people initially, if you look 10 years ago, you were given 30 tablets of Tylenol 3 or 30 tablets of oxycodone or Vicodin in the States or hydromorphone, whatever it was, and go home with this for your gallbladder, and that's it. But people, the dispensing numbers went up to 100, 120 tablets, and things like that. And that was part of the problem that they saw. The second issue was how efficacious are opiates. So we're getting a lot, you're going to read a lot in the medical press and in the popular press, and this is where we're getting pounded as physicians, that these drugs, not only are they dangerous drugs, where they are dangerous if they're not used properly, but they're also not useful. And I'll take exception with that. Romain will take exception with that. But you need to be aware of these studies. So one of the studies was looked at emergency use and people coming into emergency rooms with acute upper extremity pain. My shoulder's killing me, my arm's killing me, for whatever reason. And they randomized people to 5 milligrams of oxycodone or 30 milligrams of codeine plus acetaminophen, so Endocet or Tylenol 3, and the control group was either acetaminophen or an NSAID, and they found that there was no difference in their levels of pain. Okay, now what's the obvious thing? 5 milligrams of oxycodone is nothing. When you've got acute pain, you need 10 milligrams or 15 milligrams or 20 milligrams. So their choice of dose, if you're saying, I'm going to, hit you with a straw and expect you to get good relief compared to Tylenol, that to me was the obvious limitation with this study. They didn't give people the dose that may control their pain. I needed a root canal once. I was in agony, and I couldn't get in to see the endodontist for 5 days, and I was, given Tylenol 3. It was like candy. And I needed 4 milligrams of hydromorphone. I'd never taken hydromorphone before, but I needed it every 4 hours until I got that root canal, and then it was gone. So I had that for 4 or 5 days, right? But 1 milligram didn't touch me, 2 milligrams didn't touch me. I couldn't function. On 4 milligrams, and I was able to work. I could concentrate, and I was free of pain. So again, and that sort of, not that there's no right dose, but the point is they went with a low dose and they stopped at a low dose. The second study was a randomized controlled trial that was recently published in 2018. Again, we looked at this at Journal Club last month or in March in the Veterans Administration System, where they randomized 240 people who had a sort of a median pain intensity score of 5 out of 10 on a visual analog scale to either opiates stepped up to a dose equivalent of 100 milligrams of morphine versus non-opiates, which included SNRIs. I don't remember if it was venlafaxine or Cymbalta. I think it was the duloxetine, because that's been shown to be useful for certain types of pain. Pregabalin, and interestingly, tramadol was in the control group as well. And tramadol is a narcotic, so I don't know why they put that, but they corrected for that in their analysis because the actual number of people who used tramadol were small. It wasn't a large number of people. And they took people with chronic OA pain from back pain, chronic back pain, and chronic lower extremity pain. And at the end of their study, they found that there really was no difference in their efficacy measures, and they used a number of efficacy measures, visual analog scales for pain, pain-related function, impairment in function, et cetera, et cetera. And they found that there were increased side effects with the opiate group. So not only was the opiate group, intervention group, not effective, but people had more side effects, which you would expect with certain drugs. So I don't want to spend a lot of time, but I want to mention to you that there are problems with this study, with the interpretation of this study. And it's not a slam dunk. And it doesn't mean that these drugs aren't good drugs. And, I was briefly emailing with Romain, and we talked a little bit about this, is that if you look at it, most of these people were already starting at our target level. Our target for chronic, what's a target visual analog scale for chronic pain? How often can you take chronic pain away? Very infrequently. I treat a lot of people with chronic pain, and where I get someone who says my pain level is down to 2 out of 10. So often our target level is to get people from 8, 9, 7 down to a 4 or 5, in that range. They started with people with a level of 5. And there are other things that, and I can, when Romain does her talk, she can talk a little bit speak about this study. But you need to be aware of this study, okay? There is another study, which I thought was a very well-conducted study in Australia, where they randomized people for pregabalin, because this is what we're seeing, is because the college says no opiates, so the prescriptions for anticonvulsants are going way up, right? I got to treat someone, they're in front of me crying, so I need to give them something, and people are going on to pregabalin and gabapentin and, lamotrigine, or you name it, for their pain, carbamazepine, other things for their drugs. And in a geriatric population, these drugs are dangerous. To me, they're more dangerous than the opiates because they cause sedation, they cause ataxia. We see so many falls from the people. They cause severe edema, and I've seen people go into congestive heart failure from these drugs. So this was a study done out of Australia where they randomized people with radiculopathy. So was a very well-conducted study. People back pain, and they had radicular pain down their leg, from pinched nerves and, things like that. And they found that there was no benefit at 8 weeks being on very high doses of pregabalin. So it wasn't that they were undertreated. And they found that, as expected, there were a lot more side effects in the treatment group, intervention group. And these results are not just pregabalin, but there was a meta-analysis for all of the gabapentinoids that was published in the Public Library of Science and Medicine in 2017, and found that you're going to find the same thing if you meta-analyze the data, not just do a randomized controlled trial. Very marginal efficacy when you look at groups of people, and there's a price to pay. Does this mean these drugs are not good? There are always going to be some people, and this is one of our take-home messages, is individualized care, right? So if I start someone, there are people who get a fantastic benefit from these drugs. But if they don't benefit, stop the drug. Don't leave them on these drugs because you're putting them at risk. Epidural steroids, another one where people go to pain clinics and they get epidural steroids done, and a number of clinical trials have found very little value for epidural steroids, and even at 1 month, 6 months, and 1 year. But there are people who are going to respond to these treatments, okay? Vertebroplasty, conflicting results. There was just a study released on Monday in the British Medical Journal, which I passed over to Romaine, because I know she's going to talk a little bit about this. But there's very conflicting result. If you look at vertebral fractures, they get better with time. Most people, any bone that breaks heals. And there are a group of people that are going to have persistent pain at 1-2 months, after the fracture's healed because of the change in the architecture of the spine, stretching of ligaments, things like that. And some people may have non-union, happening. Even if you look at the placebo group in these trials, they get better. Okay, so it's a reminder to us. You may do the vertebroplasty, but they may still be getting better anyways. Now it's not to say that vertebroplasties don't work, but again, there's conflicting evidence. Acetaminophen, ineffective chronic back pain and OA lower extremity. There's been clinical trials. There's been meta-analyses up the yin-yang about this. I was doing a talk on pain last year, and someone dressed me down for even suggesting that I put acetaminophen on a slide as one of the stepped approaches to pain. And I think that's ridiculous because there are people, they take acetaminophen and it helps their pain, and they stop the acetaminophen and the pain gets worse. It doesn't take their pain away, but it makes it, it makes it livable for them. Now, again, it comes back to take-home message. If you've given them acetaminophen like 3 grams a day and they're not benefiting, stop the drug. Just stop it, because it can cause liver toxicity and renal toxicity, and it's just one more pill that they need to swallow. And finally, with NSAIDs, again, clinical trials show little benefit. There's some benefit, some of the trials positive, some of the trials less positive, most of them more towards the less. And these are dangerous drugs. This was the #1 cause of hospital admissions in North America in the 80s, was NSAID-induced GI bleeding. And I'm sure I've put people in hospital, when I was treating people in the in the 80s and 90s. Now, does that mean, again, and you're hearing me say this again, is individualized treatment? I have some people, I use NSAID as a last resort, but I can tell you, I have people come back to me and said, they've been swallowing, we see the bottle of ibuprofen on their shelf. Where did you get that? Right? That's poison. That's going to put you in kidney failure, and it's going to put a hole in your stomach and blah, blah, blah. And they say, but doctor, it's the only thing that gives me relief for my back pain or for my knee or my hip. What are you going to do? Put them on a PPI. That's what I would do. And monitor them. And again, you have to individualize our people, and they're people who find that the NSAIDs are more effective for them and more tolerable than narcotics. So the question is, what do we do now? Right? So we're basically told, we are the purveyors of this horrible opiate epidemic, which is ridiculous because most of the deaths are people from illicit drug use, but that there is a group of people, the reason they got hooked was because someone gave them a prescription at one point in their lives. This is the way people try and connect the dots. So what do we do? What do we do? This is a challenge. So I want to share a case with you and show you how I handle this and weave this into the discussion about the college. And the two nurses who work with me, Vicky, Hay, and Teresa, are here. You may recognize this person. There's a slight modification. This is a real live person with very little changes in the clinical pieces. So this was an 84-year-old woman who's a retired baker who lived with her disabled husband in a walk-up, house, where they had to actually go up a floor to get to the living area. And she'd immigrated from Germany after the war. The problems with the initial assessment, she transferred into our practice because she was not able to get out to go see her doctor anymore. She's basically become housebound. And the issues she had were spinal stenosis, generalized osteoarthritis, and she had this severe chronic pain, which we'll talk about. She also had cardiac problems. She had congestive heart failure, severe mitral regurgitation, an unstable heart rhythm. Her initial blood work that we did showed her GFR was 20. Her creatinine level was 190, and her potassium was 5.3. This is important. And her hemoglobin was 100, and her ferritin was low. So she had iron deficiency anemia. She had severe insomnia, and she had chronic constipation, and she was depressed, and she was sort of threatening, veiled threats of suicide, saying, my mother starved herself to death, and I'm my mother's daughter. Okay? So you better do something for me. Okay, so that was the starting point in our discussion. So what was the treatment history with this lady? And she was just in tears talking about her experience. She'd been on fentanyl for roughly 8 years, 100 microgram patch, and it was working for her. And she went for a geriatric assessment. Her GP got cold feet and said, I'm going to get a consultation because of this dose of fentanyl. And the geriatrician, the message the geriatrician sent back to the GP was that get her down to 50 micrograms, get her down to the college guidelines, and do it now, as soon as possible. And they tapered her down from 100 to 50 over 6 weeks. And she came back in agony, and she said, I can't live like this. And her GP said, I'm sorry, my hands are tied. This is what the college is telling us. I'm going to lose my license. If you don't like it, you can get a new doctor. Okay? And she got me. Okay? But part of it, she was in so much pain, she could not walk. She couldn't leave her house because she was in so much pain. She described her pain as unbearable. She had problems with all of her transfers. She couldn't walk down the stairs. She couldn't concentrate on TV. She was blind from macular degeneration. TV was her outlet. She could still see the TV, but she couldn't read, right? But she just found that the pain was just front and center in her life, every minute of every day. She was furious and despondent that her pain wasn't being treated. She was given Tylenol 3s, I put as consolidation, probably meant consolation. And she was taking 12 a day, and she said it was like candy. She was given pregabalin, and that made her fall and caused her to be really confused. And a low dose, 25 milligrams, very small dose of pregabalin. But these people cannot tolerate the larger doses. Not everyone, but most people. She was tried on duloxetine and amitriptyline, and she felt worse. She said, I could only take it for a week. The doctor forced me to take it. I felt horrible. She stopped it. And she said, now the doctor thought I was trying not to be cooperative. She had had injections of epidural steroids, which were ineffective, as well as acupuncture and physiotherapy. And she was taking over-the-counter 222s, which are, ASA, 8 milligrams of codeine, caffeine, etc. And she was taking, I would say, probably about 10 to 12 a day. And she said this was the only thing that gave her a little bit of relief. What do you think about the 222s, about the aspirin, codeine, caffeine combination? It helped her. But what do you think? What's the problem with those 222s? With her, from what we know about her medical history? Sorry? Yeah, her anemia, she's bleeding. She's got GI bleed, chronic slow trickle, and she's going to perf at some point because she's on this much aspirin. She's on a ton of aspirin. And what was the other problem besides the GI problems? Sorry? Absolutely. Great pickup. Don't use acetaminophen codeine very much. If I use it, I often will use it with the MTAC 30 because you'll see a lot of people, I just can't sleep. I take coffee. If I have a chocolate bar at nighttime, I'm toast. And these people are taking, a good equivalent of a cup of Starbucks with one pill, and they have 2 pills. Okay? Is there anything other problem with this drug, with the aspirin? Good. So problem number 3. What's problem number 4? Yes, her potassium was 5.3. Her GFR was down to 20. That is aspirin. That's NSAID-induced toxicity. And when we took her off it, her GFR rebounded up to 40. Okay? So this is real, and her potassium normalized. Okay. So she was begging me, saying, Dr. Rosenberg, and like clawing me, saying, put me back on 100 micrograms of fentanyl, please, please, please. And she said, I'd rather be dead. Again, she said that to me. And she, when I said, what about going back to the pain clinic again just to reassess, she said they almost killed me with the last injection. PT wasn't helpful. When we talked about CBT and mindfulness for pain, pain management, she was going to have none of that. This lady couldn't concentrate because she was in so much pain. And she said she didn't have the money to pay for any kind of counseling, and she couldn't get out of the house. So there were 3 good reasons. So functional review, and again, it comes back to this issue, is you need to really assess people. She had mild cognitive impairment, if any. She was really with it. MoCA was 26. It's about my MoCA score, okay? She scored, so that's important when you're talking and you're documenting with people. You want to make sure when you're talking informed consent, people know and they understand things. Her geriatric depression scale, we do a short GDS, which is 5.1. It's a great tool. If you score over 1, it correlates very strongly with depression, and it's sort of teased out the most important questions in the initial Savage, 30.1 that was reduced to 15 point. She scored 4 to 5, but she told me, don't be fooled. I'm not depressed, doctor. I'm in pain. That's what she told me. Her visual analog scale, we do 100 millimeter visual analog scales for pain, and she scored 75 for her back pain. We did a visual analog scale for fatigue, because a lot of these people have severe fatigue too. And she had severe fatigue. Her fatigue levels were 70. Her dyspnea level on exertion was 80. This lady was not a happy camper, okay? She had, heart failure, chronic heart failure too. Her frailty markers and functional markers, her clinical frailty scale was 5, which means that she needs help with her IADL. She probably was really a 6 because the true level 6 are people not just who need help with their personal care, but people who can't walk up and down stairs. That would put them at a level 6. We called Ken Rockwood to clarify that, and that was the initial clinical frailty scale. She had her gait speed was 0.73. This lady was crawling. She was shuffling because of her pain and mobility issues. Her grip strength was really reduced. This means this lady was frail. You can visualize her. And she was actually a bigger woman, too. She wasn't tiny. Her sleep quality was very bad. She said, I used to be a great sleeper. She complained of severe painful constipation. In terms of supports, her daughter-in-law, her dealer for Tylenol, for the aspirin and codeine, was her daughter-in-law, who was a nurse, a retired nurse, who was doing her job, advocating for her and saying, this is intolerable, right? I don't care what they say, take it. So we needed to bring all of the players on board when we made a care plan with this lady. So questions, we talked a little bit about the aspirin. What else would you do for this lady? How would you handle her analgesia problems and keep with the college standards? And this is for discussion. What do you guys think? How would you take the bull by the horns here? Would you say, I'm sorry, find another doctor? Because it happened. They had trouble finding a doctor. And, we happened to do house calls, and she couldn't get out of the house, so it was a good fit. But how would you handle this lady? Anyone? Any suggestions?
Just a reminder to use your mic, so just push the button, and when it turns red, it's your turn. That means the guys in the other room can hear you. And I haven't read the college standards. I'm just scared of them. But I was kind of wondering if I could get away with documenting what you just documented and give her the 100, because that documentation is outstanding. And I kind of feel, I don't know if this is true, this is more me making stuff up. to get in trouble with the college, someone has to complain that you're overdosing them with narcotics, and clearly she's not going to, and her sister and her daughter's not going to, because you've demonstrated that it's the right thing to do, and that's what they want. So I'm not feeling too worried that I've done it. If I've done it.
Point of fact, they do audits on people on narcotic prescriptions. When I started my practice, I got audited. I got a letter saying you're one of the highest fentanyl prescribers of family doctors in British Columbia. Okay, threatening letter from them, and we're auditing all your charts. Right? And I'd been in practice like 2 years doing house calls and frailty care in the community. And I said, fine, look at my charts, right? And what they didn't account for is that the average age of my patients was 88 at the time, and that they were frail and they had chronic pain, and they were a lot of people that discarded by the primary care system. And I got a letter back from the college saying your care is exemplary because I documented everything. And we have no problem with your use of fentanyl. So don't be afraid as long as you play by the rules, okay? And we're going to come back to that. We're actually going to look at the wording of the college guideline. Okay, any other comments? Well, anyone else? Anyone say I wouldn't increase the fentanyl? Or what do people think?
So I would actually see if she's already on 50 and amenable to kind of talking to you, then maybe it'd be reasonable to actually add like hydromorph or something like that as breakthrough and see how much she actually needs, because there could be an element of opioid-induced hyperalgesia when she's on 100.
Okay.
So try to see how much she actually needs and then go from there.
Okay.
Instead of just directly increasing it back to where it was.
Great suggestion, right? So we always need to think about, especially if you're stuck at a certain level, the two questions are, is it enough? Luckily we knew from before she had 8 years of 100 micrograms of fentanyl, which worked well for her, right? So that to me told me that fentanyl was the trick for her. But sometimes you go up and you keep going up and the pain's getting worse and worse and they may be winding up, right? So you can say, let's do an opioid rotation, change to something else, think about something else. So it's a good point there. And start with some small doses. The downside with this lady is, remember, she had very painful constipation. She could hardly move. And going to the toilet was a painful experience for her. So you'd really need to be very aggressive with laxatives with her as well. Any other suggestions?
My thought is that we didn't stop the opiate altogether. It was the dose that we reduced. So we were not achieving a great deal of benefit by putting her in such pain. So bumping up, the only thing is that we had been protecting ourselves from the college. Okay. But bumping up the dose would be definitely a reasonable option for her.
Would be a reasonable option, yes.
Option, yes.
And I want to tell people, protecting your license is very important, right? So I'm not trying to say don't, but we're going to talk that there are ways to do this right and do it properly. Okay, so yeah, bumping it up is a reasonable dose. So first thing I start with is, again, individualizing with people. What are the goals of care? So what was her main goal of care? Get rid of this pain. I can't stand it. Can't live like this. So let's say, talk with her and say, what are our reasonable expectations? And I sat down with her. I said, I'm not going to take this. If we're lucky, we're going to take this pain away, but it's highly unlikely. Let's see if we can get that down to a level 5, level 4. Is that okay with you? And then we've got reasonable expectations. She said, absolutely. Anything is better than this. Okay? So you individualize. The other thing she wanted, I want to sleep again. Well, got rid of the caffeine. That ended that problem, with the insomnia pretty quickly. And she said, my constipation is horrible. I can't stand the constipation, which made me lean more to staying with fentanyl. Because of all the narcotics, it's less constipating compared to morphine, hydromorphone, long-acting versions of those. And another consideration would be her GFR was reduced, so there's less chance of accumulation. There are a number of reasons to think about fentanyl for this lady. Functionally, she said, I want to be able to watch TV again. I can't even watch TV. I just feel horrible, and they had the German cable channels, satellite channels. She said, I want to be able to get out of a chair and get out of bed without screaming, right? Her transfers were really important to her. And to be able to move about her house again and fiddle around a little bit in the kitchen. She hadn't been in the kitchen for a while. Okay? I want to take the burden off. I feel so bad about my daughter-in-law. I'm causing them such distress, my son and my daughter-in-law. I want to reduce the caregiver, the burden on them. That was her goal. And in terms of her mortality and health directives, she was a most 3. She said absolutely no CPR over my dead body. So that's the only way you're going to get CPR. But absolutely no CPR. But she was willing to go to the hospital if she needed to, only if absolutely necessary, if she had a fracture or laceration or something like that. So those were sort of her goals of care. Okay, do we have I think we get a good feeling for what this lady looks like, how she functions, how she's suffering. Okay? Anyone have any other questions about her health status that you would want to add into that? We also measure her quality of life. We do a EuroQual 5D5L on all people, which is a 5 questions looking at symptoms like pain and mood, as well as daily function like mobility and ADL, IDL. And I forgot what her quality of life scale was, but I can tell you it was pretty poor. People, and again, we get one more objective measure of health-related quality of life. So we ended up titrating her up to 100. So I went to 62, and then I went to 75, and I went to 87. I told her it's going to take us 2 weeks, whatever. And we stopped at 100, and it was good. When she was 100, she said, I told you. Right? It's like, are you stupid? Okay. And she was aware, and I talked to her, and I said, fentanyl, opiates, you've got heart failure, there is a higher risk of death, overdose, side effects, documented. I don't care. I don't want pain. I don't care if I die. I'd rather die than live like this. Okay, that was her response, documented. She didn't want cognitive impairment. She didn't want to be dopey. That was really important to her. And no balance. And she had no cognitive impairment at 100. And she heard there was no change in her balance and no problems with falls with this lady. We talked about the aspirin. The other thing I'll mention is we put her on PEG, for her bowel management, and that took care of that, for the constipation, in addition to coming off the codeine. We tried on venlafaxine. I still felt this lady was depressed. There was part of me that said that there's more going on to this than just pain. Just to look in her face, and she was worse. 37.5 micrograms of venlafaxine. She was wired, and she felt like hell. And we tried tramadol as a breakthrough because it's a little bit less constipating than codeine. We use a fair amount of tramadol. I like it as a drug. It also gives people a little bit of a mood boost because it's serotonergic. But this lady was clear to me, cannot tolerate any serotonin, period. If you looked at the duloxetine and previously citalopram, and everyone had tried to flog her with antidepressants, they made her feel worse. Some people cannot tell, and you could see she was tremulous. She was her body could not handle serotonin, okay? So we repeated her visual analog scales. What are the outcomes? And this is documentation. So she went down from 75 to 45. It's pretty good. That's a good outcome. Her GDS, she was right. I'm not depressed. I'm in pain. Her GDS dropped from 4 to 5 to 1 out of 5. Her MoCA was unchanged with the higher dose of fentanyl, so that if you're worried and you want to document that I'm not making people cognitively impaired, even though they're on 100 micrograms of fentanyl, it's a big dose of fentanyl. And her gait speed, was marginally improved because she had less pain, okay? So the question is, do we meet the college standards? Let's take the bull by the horns now, okay? And let's look, and I'm going to take a minute, and we're going to read these college standards, okay? So the very first one, if you read this recent standard that was reduced, and it's not a guideline. They tell you this is the standard of care now. No longer a guideline. Okay, guideline means this is what we suggest. Standard of care means, your rear end is on the line if you don't follow this. Okay, number one, we have an ethical duty to deal with pain. That speaks enormously. This lady was in pain. Were we dealing with it? No, with this lady's pain. And you can read the details. And physicians must not exclude or dismiss patients from their practice based on a current use or request for opioids or sedatives or a suspicion of misuse of prescription medications. Okay? Ethical, I think, front and center, and I commend them for putting that there. Number two, physicians must base decisions to prescribe opioids and sedatives on a thorough understanding of their patient. Do you guys feel you understood this lady? I think at the end of this, we have a fairly good understanding of, who she is, what her physical limitations are, what her aspirations are, what her sensibilities and sensitivities are. So that involves conducting a well-documented comprehensive assessment, including a patient history, physical, relevant investigation results. So you need to make time for these people. Now, you can bill this as a frailty plan. Okay, so people say, I don't have time in my office. I got it backed up, and I'm going to get paid $30 or whatever the out-of-the-office visit is, or $40, for this lady, and I'm going to spend an hour with her to do this kind of documentation. So my suggestions to you would be twofold. One is you can break up that assessment into 2 visits if you need to. You don't need to do it all at once. People get tired. Or 3 visits if you need to. You're not going to be able to leave it too long because you're going to lose this lady because she's suffering. Okay? The second thing you can do is say, is there anything here that fits into that frailty management plan? Because that's a $310 visit instead of a $30 visit. And this is a frailty plan. And she can't walk up and down stairs. I didn't bill her as a frailty plan. I don't think so, because at that time we weren't sure if stair walking counted, because she still did her bathing and dressing. No one was going to bathe her, and no one was going to dress her. Right? She's a very proud lady. So she couldn't fit into that CFS 6. But we've since been told by Ken Rockwood that not being able to walk up and down stairs puts you into CFS 6. She fits it, $300. Take your time. Do a good job with this lady. Okay, so it's doable. The other thing is informed consent, number 3. So you need to do informed consent and discussion of goals of care. That's what we've done, right? We told her, here's the potential benefits, here's the potential side effects, here is a risk of death with opiates, and unusually, if it's done properly, it's very, very unusual, but, it happens. And here are your goals of care. And I would rather be dead, and I put that in my charting, than live like this. I think that's a pretty strong statement for the college. And I'm willing for them to criticize me about that. And with a veiled threat that my mother starved herself to death because she couldn't stand the symptoms she had at the end of her life. Number 4, documentation. We've been talking about that when considering continuing long-term opioid treatment. Physicians must document the discussion. And I know we get sort of, hammered to death about documentation, but this is time well spent, because it lays the map out for what you're going to do with this lady. Because they may come back to you later, the patient, and say, you said you were going to do this, or you didn't tell me this. And I can say that, yes, and this is what you told me your pain level was. I've got it right here. Do the documentation. It pays dividends, okay? And it pays dividends with the college. The B part of that is that physicians must advise patients that evidence points to risks outweighing benefits in providing long-term opiate therapy for certain medical conditions, including headaches, fibromyalgia, axial lower back pain, and functional somatic syndromes. This lady had spinal stenosis. She had real issues and severe generalized osteoarthritis. But even so, you're going to get some people with fibromyalgia and these conditions, that nothing else helps them. Just document that. Yep, this is what the studies show. We'll see if it helps you. If it doesn't help you, we'll take you off the drug. If it does help you, boom, we've documented everything. Number 7, and this is the important thing. This is where people get hamstrung and really, I think, misinterpret. I think this is a really good guideline and a good standard. For opiate doses less than 90 milligrams of morphine equivalents, the opiate dose, their standard should be less than 90 milligrams of morphine per day. But for patients on long-term opiate therapy, physicians must always prescribe the lowest, and I underline this, effective dose of opioid medication. Okay, this is the key point, effective. And if 50 micrograms of fentanyl was clearly ineffective for this lady, which was, more than 90 milligrams of morphine, it was not effective for her. So we're okay. You need to get to the effective, okay? Physicians must be confident and document that there's a substantive evidence of exceptional need and benefit. So we have our visual analog scales pre and post, with this lady function pre and post, etc. For all patients on long-term opiate therapy, but particularly those on greater than 90 milligrams of morphine per day, the merits of tapering to the lowest effective dose must be emphasized. The decision to taper must be made collaboratively. Okay, there's some patients there, they ain't going to have any of that. They're doing great, thank you, goodbye, they're not going to have it. But it must be done in collaboration with the person and with their family. So it's a team, right? Such tapers must be slow, and this is a problem people run into. 6 weeks is a reasonable taper from 100 to 50. You've got to ask the question for some people, it could really set things off. They may need a slower taper, especially with benzos and things like that. The decision to taper must be, okay, and then the college recognizes that these attempts may not always be successful. Okay? You're covered. You document it, you're covered. You're not going to be able to taper. So yes, you tried. So should we be attempting tapering? I've got people, I've got a lady I saw earlier this week with severe OA in her hip and her back, and she's on 100 micrograms of fentanyl. And she's been really good for 2 years now. And I said, you know what, let's give it a whirl. She's doing good. She has mild cognitive impairment. Let's see if we can get a little bit more mileage with her cognition. And we're going to taper slowly and see how far we can go with it. But if her pain gets worse, we're going to go right back to where we were. Okay? This is the importance of that follow-up. Guidelines number 4, 7, and 8 and to 11 are really risk mitigation. And I would strongly recommend you read those ones on risk mitigation. So that's basically considering giving people prescriptions for naloxone to take home, when they're narcotics, et cetera, and advising them and monitoring and mitigating the risks, which we should be doing. It's called our due diligence. Ian, go ahead. Yeah, I'm almost done. Okay, we're good till 7, right? Okay, sorry. Okay, it's okay if I go till 7? Okay. Okay. Okay, so I'm gonna whirl through these last couple of slides. So, talk a little bit about prevention, and I'm going to talk about this is lady 2A. Pain is getting worse. Says, "Call my pain is worse," but this time the pain is in her wrists and hands, and her fingers are numb, and she said, "My bum is killing me." Okay, so we see a lot of people who are older and frail with carpal tunnel syndrome, and I want to mention to you that there are a couple of things we can do to prevent that. A lot of these people, they just lean into their walkers, right, and they hyperextend their wrists, and it's a real problem with them. They're arthritic to begin with. So a couple of things you can do is you could use wrist splints on them, especially if it's happening at nighttime. You can pad the handles. People aren't aware, but if you make the handles thicker, they don't lean into it. And you can see here, where is it? My pointer. But you can see if you look at that handle, unfortunately it's black, but you get these big furry muffs that we get people to put on their walker handles. And then the other thing is to make sure that walker height is proper. A lot of people, their walkers are not the right height. They should be at the level of the ulnar styloid for people when they're walking, and that will help the carpal tunnel pain, okay? And finally, you can always inject some, and carpal tunnel injections are extremely easy to do, and we do them all the time with some triamcinolone or dipomedrol. Go on YouTube, and I'll show you how to do it, and you'll be very gratified. Okay. Why is your bum sore when you've got, you're not moving very much, when you're sitting in the same spot all day? This is what you're going to see. And this is the cycle I tell people with decubiti. And these can be awful, these decubiti ulcers. Not just to look at, but the amount of pain they cause people. Once they're there, it's toast. It's fighting a losing battle forever. Okay, not forever, but there are things you can do. Number one is, I say, Big Ben. On the hour, every hour, stand up, walk around. Take the pressure, allow blood to come back to those buttocks, if people are able to. Not everyone can. But the majority of people, even this lady and other people, can get up with one person standby assist, hold on to their walker, even if they can't walk. Just hold on to their walker and stand for a minute or two, let the blood come back. Second thing is to do a lap. Try and do a lap. And it's also a little bit of exercise for them. Second thing is we use a lot of barrier cream, and some people use Triad, Penitin. Just smear it on a couple times a day. It works to protect that skin. And finally, Rojo cushions. The only thing I mentioned about Rojo cushions is you need to have them inflated properly. So check it to make sure. Get the OT to go, or the home care nurse, because a Rojo cushion that's deflated is going to cause way more pain than no Rojo cushion. And alternatively, you could think about, if there's a concern about managing the Rojo cushion, use a gel pad, because those are effective also. Okay, finally, part 2B, this is true. Just before Christmas, I got a call from this lady. I'm in agony. I've got severe stabbing back pain and flank pain. Get over here as soon as possible. This is unbearable. And this is what we saw. This is downloaded from Google, but it's exactly what we saw with this lady. She has shingles, right? Shingles. And, again, it's like adding insult to injury for this lady. And just to mention about postherpetic neuralgia, is that you can compound ketamine and lidocaine into a spray. And it is extremely effective, more so I find than pregabalin or amitriptyline or neuropathic agents, and they just spray it on. And it works really nicely, and it takes the edge off it. And it's a combination of 2.5% ketamine, 2 to 5% ketamine, 2 to 5% lidocaine. The downside is you've got to pay for it, but you know what? It's a hell of a lot better than pain for people. The other thing about shingles, I'm going to make a pitch, and I do not get any money from drug companies or vaccine companies, okay? But I'm going to say this is a game-changing vaccine, the new Shingrix. And there is, I'm using the word Shingrix because there's still Zostavax, and some pharmacists are giving people Zostavax when you put Shingrix on. Here, use this instead. I don't want them to use Zostavax. It doesn't work. It's 20% effective in people over 70. This is 90% effective in people over 80, and it lasts at least 4 years. People who are older, they have a 30% lifetime risk of shingles. This is real. We see it, unfortunately, in our practice, 10 cases a year of shingles. And the risk of shingles goes up with age. And it doesn't matter if you've had shingles before. If you had it before, you're more likely to get it a second time compared to the other population. The vaccine is safe. It's been tested on tens of thousands of people. I tell people you are going to get a sore arm. 50% of people get a sore arm. You may feel like you have the flu. That's your immune system revving up, for a day or 2 or 3. But it is a lot better than shingles. And they say, but it costs $150 a dose, and you got to do 2 doses. And I say, I've got a lady who's spending $300 a day on home care because of her shingles, because she needs extra care. So, those are the things that trade-offs to people. I'll just 2 seconds mention, think about osteoporosis with prevention. This is preventable, especially people on steroids, people on androgen deprivation therapy. And there's a slide here you can look at about anti-resorptive agents. They will lower the risk of painful fractures by 50%. And there are different ways to skin a cat. Some people cannot tolerate oral pills like alendronate or residuronate. They get severe heartburn from it. We use denosumab. It's a little bit more expensive, but it works and it's simple. They're getting it twice a year. Calcium is a very little benefit. So many people are on calcium for their osteoporosis prevention. Probably does nothing, and not only does it do nothing, but it's constipating, and it's been shown to, in a number of studies, to increase the risk of coronary artery disease because it just piles up in coronary calcifications. So last slide here is that there are other useful treatments, and again, we have to look at the whole picture, and this is after the acute pain is under control. It's my experience. CBT works. There are many, many studies that show cognitive behavior therapy for pain management once or twice a week for 8 weeks. Give people the tools on how to deal with the pain. Mindful meditation and mindfulness has also been shown in a number of studies to improve, reduce the levels of pain with people, and people cope better with it. So it's an adjunct. It's not either or. Both are better than one or the other. Okay. Acupuncture has been shown to be effective for some people. Our physiotherapist does a lot of acupuncture, and for some people it's just life-changing. And there are other studies that show it's no different than a sham. Again, it comes back to treating individuals. And then there's TENS, and then there's physiotherapy and occupational therapy, which you're all aware of. So keep calm, the conclusion. I love those British sense of humor. So conclusion. Number 1 is treat chronic pain. Take-home message. That means doing a comprehensive assessment, establishing individualized goals of care for people. Start with non-opiates when possible, and you include your team. There's teams, and there are teams in the community. There's home care nurses and other people that can help you with this. Trial of opiates, use informed consent, and document things and make sure you follow these people up properly. Okay. Think about prevention when dealing with frail people in general, because a lot of pain is preventable. And finally, I'll end by saying share the care. We're a team. And these are difficult syndromes to manage as individuals. So use your nurses and physios and doctors and work like a team. Thank you.